Good afternoon, everyone. We're going to start the afternoon session. And the first talk is going to be given by John Marini, who's going to tell us about lung protection and ARDS, and specifically focus on the vascular side. Thanks, John.
Thank you, Art. I'm very grateful to the folks here for inviting me, particularly McKay and Krister Strom, and also Ivan Harold and Vladimir Cherny, good friends of mine who I've known and visited here in Prague a number of times. I'd like to actually carry along some of the themes that we covered this morning in talking about the vascular side of ventilator-induced lung injury. In lung protection, I think that almost all the speakers and speakers wherever you hear them talk about ventilator-induced lung injury will tell you that the risk for ventilator-induced lung injury is proportional to the transalveolar pressure that's applied to the lung, and that the lung recruitment may be important to avoid ventilator-induced lung injury when high inflation pressures are used. Not always, but when high inflation pressures are used. It's been a theme of our research over the years to look at the cofactors that might be important in ventilator-induced lung injury, including position, minute ventilation, vascular pressures, temperature, among others. And we have found that virtually all of these things are critically important in the expression of ventilator-induced lung injury that results from a certain airway pressure overload. I'm going to talk mainly about vascular pressure in the minutes available to me. Now, I find this a comical picture. This man is trying to think of something he knows very well. You know, what does the lung do? What does the lung do? It exchanges gas between the airspace and the vasculature. And yet, in almost every paper that's been written about ventilator-induced lung injury, we concentrate on the tidal cycle. We think about tidal volume, we think about plateau pressure, we think about positive end expiratory pressure, but we generally forget about the vascular side. Now, as the lung is distended, the blood vessels, of course, at the alveolar level, may do something different than blood vessels in the interior of the interstitium do. In the alveoli, the capillaries are compressed. Their actual volume is reduced. But very close by, in microvessels, we have distending forces because the interstitial pressures are generally quite negative in the space that surrounds the interstitial vessels. Most of the resistance change that occurs as we increase lung volume, transpulmonary pressure is on the horizontal axis, and change in vascular resistance is on the vertical axis. Most of it that responds to inflation is not in the arterial segment, and it's not in the venous segment. It's in the middle segment of the circulation, very nearby the capillaries, the precapillaries, and the postcapillary environments. And that's rather important to keep in mind as you interpret the rest of what I say. You can look at the healthy lung, airspace, 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 and capillaries in three different positions, and see that they vary rather remarkably in dimension, depending on where you are. By implication, there are stresses on the wall. Sometimes we call that hoop stress. There are stresses that are different in this capillary versus that capillary. particularly if the capillary has not had time, and emphasis on time, to adapt to the stress that it's being subjected to, the airway pressure it's being subjected to. Over time, of course, there will be remodeling, but within a breath or two or three, then there are quite different distending forces and tensions that are involved. Marcelo Amato and I wrote a paper a while ago looking at an estimation of, in part of that paper, we estimated what the interstitial pressure might be in an open lung if we put 30 centimeters of water alveolar pressure inside, a fairly common pressure to reach in the clinical setting. And based on the literature, Marcelo calculated that the interstitial pressure was minus 56. A couple of things ought to strike you about this. You've got positive pressure inside the alveolar spaces and negative pressure in the interstitium. The bigger the lung, the more negative the pressure. And those negative pressures, when they are combined with the intraluminal pressure, put a distending force on those capillaries or those microvessels that's quite high. Now, this is just a pretty picture, really. It's a ventilator-induced lung injury, and it was done at the University of Michigan by a number of investigators there. This particular paper by Rich and colleagues nicely illustrates what happens to the gross appearance and the microscopic appearance of the lung when you apply a high airway pressure at a normal rate. You get bleeding, hemorrhage. And please keep that in mind, because that is the unaccounted for factor in ventilator-induced lung injury that folks haven't talked that much about. You get bleeding under a number of circumstances, and as you change a number of parameters, you can use the same high inflation pressure at a low inspiratory flow rate. And in this experiment in sheep, protect the lung almost as if you are using low-pressure ventilation. Now, Pedro de Oliva is here, and he's done some really striking work on the dynamics of inflation. We touched on that just briefly this morning, that the rate at which these pressures are achieved may be important. And this experiment in a large animal suggests indeed that the rate of inflation is extremely important. Slow down the rate of inspiratory flow, you may be able to protect the lung that otherwise would get damaged. Maybe Pedro can talk to us a little bit during the question session or at the coffee break. Now, when we inflate with negative pressure, there have been a number of experiments. The one by Mascaroni was mentioned this morning, where the salicylate was placed in the cerebrospinal fluid and spontaneous ventilation and hyperventilation encouraged, and the animals got very dramatic injury due to the forces that were applied to the alveoli, and perhaps because of the increased cardiac output and flow through the lung. And I'll have more to say about that later. Didier Dreyfus, back in '92, showed us that actually using negative pressure to inflate the lung was no protection against ventilator-induced lung injury. And in fact, those animals did slightly worse when tidal volume was achieved by negative pressure versus positive pressure, possibly due to vascular forces. These are images from one of his summary papers. And the only thing I want to call to your attention is that within 20 minutes of inflating lungs, I believe these are rabbit lungs, and these they were inflated ex vivo, I guess, but you see a hemorrhage occurring in a perfusion state. Actually, these were intact animals, and those those animals' lungs were bloody and hemorrhagic after a very short period of time, suggesting vascular trauma. I use it only to ask the question, how does this hemorrhage occur? In our own experiments in large animals, we found a very peculiar thing when we applied only high inflation pressure and low PEEP. What did we find? We found that the most stretched areas were hardly injured at all at the end of 4 to 6 hours. This is the heart in the center of this heart-lung block taken out of the large animal. And you see that the areas which are most ventral, most likely to be overstretched, are actually the best preserved. Whereas, I don't think I did that. Thank you. Whereas in the dependent zones where collapse and reopening, and certainly the high forces of inflation might be expected to be greatest, we found bleeding, we found hemorrhagic edema. These were inflated lungs at 20 centimeters of water PEEP after the atelectasis had been taken away. So it might just be that it's collapse and reopening that's the important thing. But there are several other features, okay? One is that the vascular pressures and perfusion and flow to the dependent areas is greater than in the ventral areas. So that we envision that the hemorrhage and damage occurred in a sequence that went from bottom to top. And in fact, as you put these lungs in a more natural orientation, you see that the bleeding or the damage has gone across in almost a linear way across the bottom part of the lung. Now that's quite interesting. It actually crosses anatomical boundaries that separate one lobule and one lobe from another. Is there anything else that happens that would favor dependent injury? Well, it's not the topic of my talk today, but I would say that once edema begins to form in the alveoli and they begin to flood, then that edema has protein in it that can inactivate surfactant. It also has inflammatory material in it, which, if it bridges over into another area, will start an inflammatory process locally as well. The kinds of things that influence the movement of edema in the airways include the edema quantity and the ventilatory pattern, particularly tidal volume and PEEP, and also position. Gravity is a very important determinant of what happens to airway fluids. And these airway biofluids we've been talking about are rich in inflammatory mediators and in high concentration. So could it be that we're overlooking an important feature, protecting our patients from ventilator-induced lung injury by not hydrating them, for example? As I say, it's not my purpose to talk specifically about this today, but I would have to say that the work of DeProst, Shortgen, and Dreyfus again has shown us that change of ventilatory pattern in a lung protective way can prevent labeled albumin from spreading all throughout the rabbit lung. Here you have some labeled albumin instilled within the alveoli. And when you ventilate the lung gently, 8 milliliters per kilogram and 2 of positive end expiratory pressure, basically after 10 minutes, everything's the same. If you use a tidal volume that's 3 times as large and do not use any end expiratory pressure, it disseminates widely. And if you use a large tidal volume again, but use 6 centimeters of positive end expiratory pressure, which is a lot for a rabbit, it keeps the labeled albumin in place. What is the point? The point is you do not want vascular leakage to encourage edema formation and this inflammatory edema to spread throughout the lung. What does it cause? We don't know. We're working on that at the moment. We think it may indeed contribute to ventilator-induced lung injury. Perhaps you would agree with me that we see many patients like this. This patient I treated in 2006 who came in predominantly with a left-sided pneumonia. And we treated her as we always do. She required mechanical ventilation. She was intubated. And the next day, her lungs looked like this. And when I went through training, we would say, gee, we hydrated the patient, and the patient became, the pneumonia blossomed. Okay? But in this case, the patient went from localized lobar pneumonia to ARDS, possibly because we hydrated her. The very mobile edematous inflammatory material was propelled throughout the lung. Did it happen that way? No, but the time sequence was good, and it's certainly consistent with laboratory experimentation. Microvascular events do impact ventilator-induced lung injury. Vascular dynamics have the potential to modulate ventilator-induced lung injury. Increasing the hemodynamic pressure gradient across the lung's microvessels worsens ventilator-induced lung injury, and I emphasize gradient for reasons I'll show you in a moment. And when tissue stresses are sufficiently high, this is not in all cases, but when the stresses are high, increasing the respiratory frequency or the minute ventilation may worsen ventilator-induced lung injury. The work of John West has been referred to already this morning. Basically, in static lungs that were not ventilated, he showed that when capillary pressures reached a certain threshold, which was about 40 to 45 millimeters of mercury in rabbits, there were tears, and you can see a red blood cell extravasating into the alveolar space. The kind of pressures we've been talking about just now with the trans microvessel tension that might be as high as 56 centimeters of water outside and maybe 10 millimeters of mercury inside would exceed the levels that West showed in static lungs, would cause real breaks and tears in the membrane. Now, this membrane is not endothelial, it's not epithelial, it's both. And if you think about it, it's hard to come up with another way in which red blood cells can get into the alveolus except through tearing. You can't get them through another cell. They must go through separations, real tears between cells, and in this case, it's fairly obvious that it's an artificially induced tear. This work was done by John Hotchkiss and by Alain Brocard. Actually, 10 years ago, we began these experiments, and I'll just summarize them for you here. We did isolated, ventilated, and perfused experiments, and we did that because we could control the microvascular pressures upstream and downstream of the alveolus, and we could also modify the alveolar pressure. We put a little bit of blood mixed in with a Krebs-Sensolite buffer system in order to be able to demonstrate where the damage was occurring. The similar preparation was used by Luis Blanc, Lopez Aguilar and colleagues in 2006, where they were trying to separate out whether it was the vascular pressure or the vascular flow which was important. And in summary, they found that the high flow states that are associated with a gradient across the alveolus at the microvascular level were associated with hemorrhage and edema. Now, in our experiments that preceded these by quite a long period of time, we also looked at hemorrhage score, and we looked at a potentially ventilator-induced lung injury pattern. I'm thinking it was 30 centimeters of water airway pressure and 3 centimeters of water PEEP. And we used a breathing frequency of only 20 cycles per minute at baseline. The control pressure on the upstream side of the alveolus was 20 millimeters of mercury. And we found under those conditions very little evidence of hemorrhage. When we used exactly the same airway parameters and used a frequency identical to the baseline, we found that there was a very high hemorrhage score. What's intriguing about this work is, I think, is that when we kept all the vascular pressures the same, mean pressure, peak vascular pressure, but the only thing we changed, the only thing, was the breathing frequency. We lowered the breathing frequency to only 3 per minute. So you have alveolar pressure at exactly the same levels, vascular pressures at the same levels, same tendency, you would think, to cause hemorrhage, and you've caused much less. Why is reducing frequency protective? Still haven't answered that question exactly. One possibility is that in increasing the CO2 environment of these lungs, which were probably living but not, there wasn't a lot of carbon dioxide being produced. We did try to regulate that, but it is possible that locally we went from a eucapnic state to a hypercapnic state as we lowered the breathing frequency, and that protected against the inflammatory changes that would otherwise be there. But now remember that these were white cell-free perfusates. This was a Krebs-Henselite buffer with a little bit of red blood cell thrown in as a marker. It was not blood. So the inflammation piece of it we would think be markedly attenuated in this preparation. First possibility, acidosis or at least less alkalosis than we were dealing with. Quite possible. A second possibility is increased tidal wound healing time. And Rolf covered this so much more elegantly than I could possibly do. I'm grateful to him for that. Basically, it is possible that when you're breathing at a normal frequency under this kind of stress, you cannot repair the plasma membranes as quickly as will happen if you allow a longer period of time. Certainly, Dreyfus, again, we owe a lot to Didier, showed us that you can demonstrate a fading edema over 5 minutes of its induction if you change the ventilator inflation strategy. I think this was actually seminal work that has been sort of sitting on the sidelines for a while. There's some other recent papers Krista and I were talking about recently that are consistent with this idea, and Rolf covered this beautifully this morning. In fact, his work where if you apply a label that looks at plasma membrane rupture after the ventilation process, injurious process has occurred, you find much less cell injury than if you apply the label during the ventilatory process. So maybe we were just allowing more healing time as we lower the breathing frequency. A third possibility, and I still think this is an important one, is cumulative damage. It could be that we injure and then it takes multiple cycles that accumulate in their effect, and maybe we cross a threshold of either structural integrity or an inflammatory boundary, and we have a tear-away exponential process. Luciano Gattinoni and I wrote a summary paper of ventilator-induced lung injury in critical care medicine, 2004, and we are emphasizing what was already well known, that tidal forces call them transpulmonary and microvascular in nature. If they're moderate, can definitely signal inflammation if they're repeated. And the mechanosignaling via integrins, the cytoskeletal and ion channels leads to an inflammatory cascade, cellular infiltration, and inflammation. In certain cases, however, there is rupture. Extreme stresses and strains, whether they be generated at the vascular level or inside the airway, can tear membranes. And when that happens, you fall immediately to a wounded lung, and cellular infiltration and inflammation occur. Does this happen in the clinical setting? And we think that it does. This is work from a paper of Dreyfus. Here you have the Bleb formation that I think Rolf showed us earlier, a very early change. And later, only 20 minutes later, there is no membrane left. It is shattered. It is broken. And red blood cells, we would think, should be able to find themselves inside the alveolus. That's a very short time for an inflammatory process to occur. As we look at the weight of these suspended lungs that Hotchkiss and Brocard and I worked with, our vascular pressure was 35, left atrial or outflow pressure was 10, peak of 30, PEEP of 5, inspiratory to expiratory time ratio of 0.5. For the first almost 10 minutes, there's no change. And then suddenly, at about 10 or 11 minutes, you begin to get on a tearaway exponential function of weight gain. What causes this? It's definitely flooding of the lung, but it's almost as if something finally gave way. We think of it this way, and Luciano Gattinoni thinks it is definitely something to consider. If you have multiple stress-bearing fibers and eliminate some of those fibers, you move from a load on each one that was modest and tolerable to something that is intolerable as you progressively load the system. You begin to pick off the rope fibers until there's only one or two left, and finally there's breakage, there's leakage, there's a catastrophic failure. Does it occur? These are from our laboratory, not from Dr. West's laboratory. And you see here the kind of splitting of the barrier that you might anticipate. And is collagen strong enough to bear the tension? Yes, I suppose, but it's certainly rearranged differently when you look at it in autopsy or after the end of the experiment. That exposed collagen has many implications, but the one I'm going to concentrate on here is that it could be breakage of the structural elements, particularly if they're weakened by inflammation. We've shown you already that increasing the upstream microvascular pressure when there is a high alveolar pressure and low PEEP applied to the airway will cause dramatic evidence of ventilator-induced lung injury. What it may surprise you is that if you keep this pressure the same and normal and lower the pulmonary venous pressure, that the problem gets worse as well. Moreover, it may be interesting to you to note that recently Brian Cavanaugh and his group have shown that in rats that were conditioned with hyperoxia for about 30 days to give them pulmonary hypertension, they had much less damage than rats that were natively exposed to the same stress forces. The pulmonary hypertension appeared to be protective, maybe because it was protecting the microvessels, maybe because it was taking the high vascular pressures off the microvascular portion of the circuit and loading it onto the larger vessels. This is what Brian's interpretation is. In Brocard's study of of lowering venous pressure, you can see that edema does not form and permeability does not occur if your alveolar pressure is in a reasonable range of 20 or 25 centimeters of water. But when you put sufficient stress on and lower the left atrial pressure, suddenly edema and permeability become an issue again. This is not what you would predict from classical teaching of congestive heart failure, for example. It's certainly not congestive heart failure. And potential mechanisms are interesting to think about. Some that came to our mind are energy dissipation, vascular interdependence, and endothelial shearing forces increasing because of the vascular pressure gradient. Now, to make this a little more clear to you, this is a normal lung, and you can see under zone 3 conditions, all the capillaries are open. Under zone 2 conditions, there is narrowing of each capillary, and the velocity of shearing across the surface must increase. And if you lower the venous pressure enough, then you create zone 2 conditions that would allow intensified vascular velocities and perhaps endothelial shear to occur. The implications of this work, I think, are again, for us at least, interesting to think about. You dissipate more energy. You dissipate energy across the alveolus when you create a pressure gradient across the alveolus. So there's more energy delivery to the alveolar level. And endothelial shearing forces also increase. Now, these things are influenced by cardiac output and minute ventilation. And there's an emerging theme here that reducing oxygen demand and ventilation targets may lower the risks for ventilator-induced lung injury. We seldom talk about that, but I think it's very important in the first stage of caring for these patients that we don't let them labor. Again, we talked about this morning a little bit. Do not let them labor in an attempt to keep them off the ventilator or once on the ventilator to preserve spontaneous breathing. Yes, gentle ventilation might be a useful thing, but so often our patients are acidotic and are breathing rapidly and require high cardiac outputs, are pouring a lot of blood through the lung, developing large gradients. We're using high pressures because of ventilation requirements, and we are probably precipitating ventilator-induced lung injury. Ventilation requirement, ventilation pressures and cycling frequency would be reduced by lowering the ventilation requirement, and cardiac output reduction, of course, would reduce the microvascular pressure gradient because it reduces blood flow. Now, just some images of normal perfusion-fixed rabbit lung. You see all the architecture is quite delicate here. You've got large vessels and you've got many smaller vessels. This is what happened to our preparations. These are red blood cells extravasated around a microvessel. That blood should not be there, and it is. Tears in the fabric of the lung in the indicated places. You can see red blood cells ready to emerge into the alveolar space. Close up. These are not natural formations, and they're not artifact of the preparation. Here's another. This almost looks like one of Dr. West's pictures, but it isn't. It's from our laboratory. Pure ventilator-induced lung injury caused that problem. Now, are human beings like small animals? And the answer is yes and no. We are not like the mouse, the rat, the hamster, the rabbit, which have less alveolar volume and less collagen than do humans, monkeys, baboons. And so you might think that this work is marginally questionable on that basis alone. I think so too. However, this is a normal human lung architecture. Doesn't look a great deal different than a small animal or a large animal. And this, unfortunately, is the image of a patient on our surgical service. I will say that I did not manage this patient, but this is a patient that we published in the Critical Care Medicine in 2004. Those tears are every bit the image of the tears that we found in the laboratory. And this kind of damage cannot be accounted for by either laboratory artifact or by any natural disruption. When you have a disruption of that magnitude, you do not need mediators to establish a connection between the alveolus and the periphery, because through such portals can go bacteria, can go gas, microbubbles, and both have been shown to occur in experimental settings and in clinical settings. Dr. Lachman and Verbrugge and colleagues here in Europe, and actually slightly before them in our laboratory in large animals, Avi Nahum and our group showed that if you inoculate the trachea with a marker bacteria and you look at positive blood cultures at 0 to 6 hours in a large animal, and dogs are tough. They're like human beings. They're tougher, actually, in many respects, as in their resistance to bioinjury. If we used high alveolar pressures and low end expiratory pressures, we got almost immediate, this is the first time we measured it, at 1/2 hour, we got 80% of our animals had positive blood cultures. And they continue to be positive at 1 hour, at 2 hours, 3 hours, 4 hours. This is long before you establish an infection. These are not infective doses of tracheal inoculum. This is an important point, I think. And Verbrugge showed the same thing. When you use the same high inflation pressures but high end expiratory pressures, then only one animal showed bacteremia of six animals in each group. If you use lung protection, low inflation pressures, and even with low PEEP, so you might have had some collapse, you don't get any blood cultures positive. I think that has a message for us. We need to be concerned also about air bubbles that are percolating through the right through the left atrium in this picture. I think this is from Jean-Jacques Ruby's work. Phasically with the ventilatory cycle, once you get those tears, those microbubbles may do no damage at all, or they may coalesce to cause microinfarcts, or they may, in and of themselves, cause inflammation at the periphery. So, in summary, the vascular side of ventilator-induced lung injury it's a little bit complicated, but it has elements that relate to the decreased interstitial pressures, the increased transmural vascular pressures, the increased vascular resistance in the middle segment, much microvascular stretch and strain, structural vessel failure leading to edema, and ventilator-induced lung injury. Potential clinical relevance: inotropes and pulmonary vasoactive drugs influence the pulmonary vasculature and the various segments of the vasculature. This is one we were talking about at lunch. The wet versus dry approach to fluid management may affect much more than just cosmetic factors. The amount of volume that we give our patients is often excessive. Metabolic rate control, ventilation targets, breathing pattern modification, redirection of blood flow occurs with positive and expiratory pressure and with recruitment, and I'm sure you can think of many other reasons why we should be concerned. Thank you very much for your attention.
Thanks very much, John. Any questions from the audience?
Thank you for the talk. It was mentioned about frequency and tidal ventilation. I'm a little confused about hyperventilation. When one's speaking of hyperventilation, are you talking about large tidal volume, small tidal volume, rapid rate? Obviously, with low tidal volumes, we use high frequencies. I've always been of the opinion that high frequencies are dangerous for the lung, but nobody else has ever said anything about this. Now, you're talking about breathing pattern modification. Could you somehow reconcile all of those things together and talk about frequency of the ventilator and that sort of thing?
Yes. The first thing I will say is be careful before taking laboratory information and directly translating it to practice. I'm convinced of these things, and just my opinion from here on. First of all, I think breathing frequency makes very little difference if the stresses on the lung are not excessive. So, for example, a high-frequency oscillation probably is lung protective, even though the frequencies are very high. But once you reach a damaging force across the barrier, from the vascular side and the alveolar side, then reducing the frequency either changes the signaling, or it prevents materials failure of the collagen. I think it's just a common sense idea to, when you're on the margin, or frankly in the range of ventilator-induced lung injury, to reduce the breathing frequency. As for breathing pattern modification, there's a lot to say there, and in fact it's not all known by any means, but if you take the same amount of cumulative pressure and distribute it in a biologically variable way, such as has been done by a number of investigators, Suki is one, and Much is another, and many more people have been interested in that area, you have a tendency for lung protection and at least improved recruitment, et cetera. So the variation may be a part of it. But more importantly, and I wish Pedro would say something about this if you're inclined to, the rate, the flow rate, and the velocity with which the lung is stressed may be extremely important. One part of it you're not going to easily get around. If you use a high pressure, you're going to find some lung units that are rapidly being pulled on when they cannot follow quickly enough. So the dynamic part of that is important. So I think there are things to learn about the flow pattern, the variation in tidal volume, not just tidal volume and PEEP, but whether it's spontaneous breathing or controlled ventilation. From my point of view, in the first phase of ARDS with a really sick patient, I like to take control of the patient for the first 24 hours, 24, 48 hours, cool them down, so to speak, get control of the factors that caused them to get sick, if I can, and then slowly take away those strong supports.
Rolf? John, I'm intrigued with your initial example where the ARDS blossomed as a complication of this unilateral pneumonia. Mm-hmm. And there are, as you point out, there are two ways to think about this. Either it's an airway contamination of the other space. So when we talk about bilateral pneumonia, the assumption is that there are bugs on both sides. But as you know, it's just as likely that the other lung could simply have this innate immune response to having a local infection here that then turns into a sterile, inflammatory something. Do we know anything clinically from regional bug sampling or stuff like this, how this works?
Well, I certainly am as intrigued as you are by it. I'm intrigued because there's therapeutic potential. And as you can see, if we reposition our patients from the get-go, when fluid we've just resuscitated the patient, there's a lot of liquid to pour back and forth, we may be doing exactly the wrong thing then, and later on we may need that turning to ensure recruitment once the fluids have thickened up. But no, Rolf, I don't have any data. We're obviously interested in that area. It's very few people have known how to track secretions inside the airway, for example. This is a radiological problem that seems to be relatively fresh, and we've been working on that. But until we get that information in, I can't separate whether it's a second hit going on in the lung that wasn't initially inoculated, or whether it's new inoculation by coughing that we do, or if it's flooding, or what the explanation is. I do know that when people tested this back in the 1930s with infection, they were very interested in preventing multilobar pneumonia. And they found that by positioning dogs differently, they could prevent multilobar pneumonia. And if they inclined them to a different position, they would get cross-contamination just that way. It's easy to understand with infection. Whether it makes any sense for ARDS, I don't know, but I do know there are things that would tend to mobilize edema and tend to encourage what we call propagation injury.
Jesus?
Yes. John, you talk about endothelial rupture, endothelial injury. You talk about the importance of the flow, etc., and even a little bit about the presence of extravascular lung water in the lung, how that can influence, the flow and pressure inside the capillaries. But I think it's an important part of this the story is about the in patients with established ARDS, they have pulmonary hypertension, and they have pulmonary hypertension due to activation of coagulation and a decrease on fibrinolytic activity. So that will give you a role, ideally, in theory, to give anticoagulants to patients with established ARDS, or even to give fibrinolytics, to activate fibrinolysis. So what is your comment on that? Because I would like to see pictures of the lung in patients with ARDS, in which you can see a microthrombi, a lot disseminated across the lung. So that will give us a, some therapeutic option that I never hear about that.
Well, I think it was Warren Zapal a long time ago was very interested in the pulmonary hypertension of ARDS, but usually that's someplace down the line. I think ventilator-induced lung injury really happens primarily in the beginning, when we're trying to stabilize the patient.
And it's not followed by activation of coagulation?
Well, I'm not saying it isn't. I think your points are well taken, but as Kavanaugh was suggesting, the development of the pulmonary hypertension actually may protect against further ventilator-induced lung injury. So it's possible that pulmonary hypertension, once it develops, is actually protective. And I don't know enough to interfere with it by, fibrinolytics or anticoagulants or anything like that. But these are interesting questions that have not been asked. Thank you.
Thanks very much.